the Understanding MACRA Quality Payment Program, MIPS Advancing Care Information Catalog. My name is Adrienne, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we'll conduct a question-and-answer session. I'll now turn the call over to Lori Mansfeld. Lori, you may begin.
Hi, thank you so much, Adrienne. Hi, everyone. My name is Lori Mansfeld, and I am greeting you today from Wisconsin. I'm a project specialist here at MetaStar, which is the QIO, the Quality Improvement Organization for the state of Wisconsin. I do speak the language of meaningful use just to let you know a little bit about my background here at MetaStar. Is I've been working specifically on meaningful use through our Medicaid HIT extension program here in the state of Wisconsin, where we have helped we're in the process of helping about 1,200 Medicaid enrolled providers reach meaningful use. So I most certainly speak that language very well, very fluently. And I also, the Lake Superior Quality Innovation Network is made up of 3 quality improvement organizations, MPRO over in Michigan, as well as Stratus Health in Minnesota. And I'm happy to say that I do have representatives from both of those states as well here on the line with us today to help answer state-specific questions and just provide some additional information. The role of the Lake Superior QIN really is to provide to be in collaboration to improve healthcare for Medicare consumers, share best practices, and really to maximize efficiencies. The objectives for today's webinar, first of all, is to provide a brief, and I'm going to underline the word brief, context of the Advancing Care Information category within the Quality Payment Program. Now, for those of you, if you are looking for a more general overview of MIPS and the Quality Payment Program, I just wanted to mention to everyone that there is a link to a very nice recorded webinar that the Lake Superior QIN did in November, and that is available on our website, which I will be, we do have a link to that provided in the presentation, at the end of this presentation. This is really meant to be a deeper dive specifically into that ACI component. Moving on to our objectives, we'll also understand the eligibility requirements for the ACI and relating of the category whenever applicable. Also understanding the objectives for the measures for the base, performance, and bonus sections. We will be clarifying the scoring of the ACI category within MIPS, and then you'll also be able to gain some knowledge about some key resources and tools that will help you to learn more, as well as what you can expect from the Lake Superior QIN. And with that in mind, once again, I'm going to be providing a brief context of the ACI category in the QPP. First of all, as most of you are well aware of, just a very brief program overview is that the Quality Payment Program policy really will reform Medicare Part B payments for over 600,000 clinicians across the country. So this is a very major step. Clinicians do have a number of ways that they can participate in this quality payment program based on their practice size, specialty, location, or patient population. And just to remind everyone, there are 2 tracks to choose from. There's the advanced alternative payment models, or the merit-based incentive payment system, or MIPS. And ACI and the ACI category, and what I will be discussing today, is specific to that MIPS track. So who participates in MIPS in 2017? This would be Medicare Part B clinicians that are billing more than $30,000 a year and provide care for more than 100 Medicare patients in a year. And these eligible clinicians can be physicians. This includes MDs, DOs, chiropractors, ophthalmologists, as well as dentists, physician assistants, nurse practitioners, clinical nurse specialists, as well as certified registered nurse anesthetists as well. So who doesn't participate or who's excluded from MIPS? And there's really three categories here. First of all, those that are newly enrolled in Medicare. Secondly would be those that are below the low volume threshold. And as you'll notice here, it's underlined in OR. So these would be Medicare Part B clinicians that are charged with charges less than or equal to $30,000 in a year, or they see 100 or fewer Medicare Part B patients in a year. And then also those that are participating in the advanced APMs, that are significantly participating in advanced APMs. Okay, very briefly, this slide shows the MIPS performance category weights for 2017, and the weights are assigned to each category on a 1 to 100 point scale. Specific to the advancing care information, I just wanted to draw your attention to that for many clinicians, or for most clinicians, would be at 25% of their overall MIPS score for 2017. And specifically, the people who are affected by the MIPS ACE category would be about 92 to 95% of all providers in 2017. Those are the ones that are either in MIPS as eligible clinicians or that are in MIPS APMs, meaning that they still are eligible for MIPS even though they are part of an advanced APM. This is one of the other big differences between the Quality Payment Program and the Legacy Program, specifically meaningful use, and that is that clinicians can participate either as individuals or as a group. As an individual, that would be under their NPI number, but as a group, I will actually get into more detail on this on the next slide, because this is a common question that I've had in my own mind. Is that the Advancing Care Information Performance Score, the way that it will be reported as a group is that basically all clinicians' performance under 110 will be aggregated together, and so it will not be individual, as has been the case in the Meaningful Use Legacy Program. Also, if you're reporting as a group, or if you plan to report as a group, hospital-based MIPS-eligible clinicians do not need to be included in the group calculation for the Advancing Care Information category. More detailed guidance on how exactly this will work will be provided later in the year, hopefully sooner rather than later. Moving on to a bit more explanation around the Advancing Care Information category. First of all, there are some exemptions from ACI. So I wanted to throw this out there right away so that everybody understands that there are a group of people that will not, or a group of clinicians that will be exempt. And that these exemptions I'm talking about, I want to make it very clear that these are just for the ACI categories and not for MIPS in general. Okay? Also, a very big difference between the Legacy Meaningful Use Program and the new ACI category is that there are no longer individual objectives or measure exclusions, only the whole ACI category exemption. And as we get into the measures, I'll be describing that in more detail as well. All applications must be submitted annually, and categories of hardship exemptions, very similar to hardship exemptions under meaningful use, will still be available. Specifically, these are sort of two lists to think of for the MIPS-eligible clinicians where their scores would be reweighted to 0. So if they're not eligible for the ACI category, their score for there would be reweighted across the MIPS categories. And that would be for one of these three reasons: insufficient internet connectivity, extreme and uncontrollable circumstances, think natural disasters, or the lack of control over availability of search. These MIPS clinicians would need to submit an application for CMS reweighting of the advanced care information performance category to 0%. And once again, we'll be finding more about that application later in the year. Also, and this will be very familiar to some of you, or look familiar for those of you who know meaningful use. If you're in one of the following categories of MIPS-eligible clinicians, you would automatically be qualified for that automatic reweighting. And that would be hospital-based MIPS clinicians, physician's assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, as well as clinicians who lack face-to-face interaction with patients. And this is what that reweighting looks like, okay? As you can see here, advancing care becomes 0, and that 25% gets added to quality. So quality at that point would have, in those circumstances, would have an 85% weighting, and then improvement activities would remain at 15. And so, just looking at then the ACI categories, and this slide has a lot of information. So I'm going to sort of cut it into two, because in 2017 there are basically two measure sets for ACI, and it's really based on your EHR certification edition that you're using. So off to the right is honestly where I'm going to spend the most of my time and use the majority of my examples, and that is because 2017 is a year where there are transitional objectives and measures. And for those of you familiar with meaningful use, they basically follow the meaningful use modified stage 2 objectives. And so only 2014 cert would be required to meet those objectives. For those on the left-hand side of your screen, this would, for those of you familiar with meaningful use, follow much closer to the stage 3 objectives, which in 2018 will be required and will require the use of 2015 cert. Okay? You also have an option of a combination of the two. So many organizations are going to be upgrading to the 2015 edition of CERT sometime during the year, and so that is also allowed. At this point, I did just want to take a quick pause. And Mona, were there any chat questions that we wanted to answer right away?
There are no chat questions right now.
Okay. Well, I hope that doesn't mean that I've thoroughly confused everyone or that you've fallen asleep. So, moving on to the MIPS scoring for advanced care information. And this just once again, and we'll be getting into scoring in more detail shortly, but the ACI category does make up 25% of that final score. And the ACI score is made up of three components: the base score, which is required, the performance score, and the bonus score. Okay? So first, I'm just going to dig in a bit more into what these base measures are. And once again, I'm going to be referring to the right-hand side of the screen. So for those of you who are currently using 2014 CERT, these would be the 2017. That would correspond with using these 2017 transitional measures, okay? And the first objective, which will continue to be there for 2017, 18, and beyond, is protecting patient health information, so conducting a security risk analysis or review. This will continue to be a yes or no attestation or filing. Objective number 2 is electronic prescribing. This also is only included in the base score. In order for it to count towards the base score, you would need 1 in the numerator. Okay, so basically showing that it's functional. Patient electronic access, that would correspond with the measure providing patient access. So basically having summaries sent out to the portal, so that would be pushed out. And that one also would be required for the base score to have a numerator of 1. And the same would be true for health information exchange. And the health information measure in this case is really the transitions of care. Once again, you would need to have at least 1 of those. Okay? And then for the 2015 cert, those I also have listed here. For those of you who are familiar with the Stage 3 meaningful use requirements, this basically follows suit. Moving on. Okay. This gets into the performance measures. The performance measures, you'll probably notice 2 bright red stars here off to the right under the 2014 cert. For 2017 only, these 2 measures will be weighted at 20% of the total performance measures score. All of the other measures will be at 10%. And this is also where, for each one of these, this would be a numerator over denominator sort of a calculation. So specifically, and the way that it would work, I'm going to use patient-specific education just as an example, all right? If you have a numerator of 81 over 100, it would actually round up to 90%, or a 9 points for that particular measure. So you would be meeting that at 9%. So each one of these would be weighted that way, with the exception of the public health reporting, the immunization registry reporting. That would once again be, active, that you would need to show active engagement and attest to active engagement. And so for these performance measures, the higher your numerator is as compared to your denominator, or the higher percent of performance, the more points you would receive. There also is a way to get bonus points. There's really 2 ways. The first way is registry reporting, and this would be a 5% bonus. And for 2014 cert, that would basically mean either reporting for syndromic surveillance or specialized registry reporting. Now, speaking specifically to the state of Wisconsin, back in April of 2016, DHS did report that the state of Wisconsin would not be accepting syndromic surveillance from ambulatory centers. So for anyone who had not already been set up to or were not already in active engagement with the state of Wisconsin for syndromic surveillance, that is no longer something you'd even be able to do. So for the state of Wisconsin, in order to get this, you would really need to be doing the specialized registry reporting for this bonus. And once again, if you do have the 2015 cert, that very much follows the public health objective in Stage 3. All right. The second way to get the ACI bonus would be improvement activities. That kind of corresponds and dovetails off one of the other MIPS categories, the improvement activities, there are a list, and I have a link right here to that list. And there are selective improvement activities that have been identified as involving certain can actually boost your advancing care information category, but that is valid only for 2017. There are approximately 18 activities to choose from there. One of the activities is the, of course, I can't think of the exact name, but basically improved access for patients, which basically would mean that there would be improved access to clinicians, and that those clinicians would have would be able to go into the EHR and see the patient's electronic health record, and that would be part of that improvement activity. So that's one of the examples of the 18 that are out there that would earn you that bonus point. Now I'm going to move on to ACI scoring as part of the overall QPP score. Just a reminder that since 2017 is a transitional year, CMS is offering Pick Your Pace, which really is a set of on-ramps for MIPS participation. The test pace, which is basically submitting some data, one of the ways to reach that, for the payment adjustment to be neutral and to avoid any penalties would be to get the 3 MIPS points simply by completing the ACI or meeting the ACI base objectives that we had talked about earlier. So that's one of the ways that you can at least avoid the downward payment adjustment. Now, if you report there's also the option of reporting for a partial year, which would be a 90-day consecutive, any 90-day consecutive period after January 1st, 2017 for a small positive payment adjustment, or the full year, which would be fully participating from January 1st, and there you could expect a modest positive payment adjustment. And the next slide is just a reminder of where that advancing care information would be 25% of that overall weighting, as I had described earlier. And this is really how that scoring works, okay? There's the required base score, which makes up 50% of the score. The performance score, which can be up to 90% of the score, and then the bonus score, which is up to 15% of the score. And as you guys will notice, your calculators, when you add them up, it comes to 155%. And that the category is capped at 100%. Now, one of the things that you'll notice on those performance measures are two of the measures that do require patient activity. And I think this is one of the reasons why there's this idea of a cap, is that it's not expected that you would get all 90% of that performance score, have a perfect score there, or have a perfect score even for the bonus score, just as an example, especially in this initial phase of this program. Speaking to that, in the performance score, as I mentioned, there are two measures or objectives that do require patients to do something, and that would be secure messaging as well as view, download, or transmit of their online patient, through the patient portal. Well, for example, for those, chances are that you will not have 100% of patients doing that. Now, you will get more scores the more patients become engaged and log into the portal and send secure messages, but chances are that it will never be at 100%. And so that would be just one example of where, it's capped at 100%. Especially since, as I mentioned, the exemptions and exclusions that you are most likely familiar with for meaningful use no longer apply in this new world of ACI. This once again looks at the MIPS 2017 scoring. There's the 3 points for a neutral or basically no payment adjustment. If you don't meet that or you do nothing, that's when you'd have a negative payment adjustment. If you do reach 4 to 69 points, you will receive a positive payment adjustment. No exceptional performance payment, but also no negative adjustments either. And if you're at 70 points, or higher, that's where you would be eligible for a positive payment adjustment and exceptional performance bonus. And once again, ways to get at least the 3 points to avoid a downward adjustment or penalty would be to report ACI for the 5 required base objectives. That would get you to 3 points. Also, reporting just 1 quality measure or 1 to 2 improvement activities or being part of a medical home would also get you to 3 points. And then I just wanted to introduce some resources and tools. And first of all, I wanted to just emphasize the work that the Lake Superior Quinn and the role that we are taking in the QPP. And the number one that all of you are already participating in is the education. We will be providing throughout the year, as well as next year, many webinars as well as open office hours to provide education and guidance as we all get used to this new program. We will be providing technical assistance, so if you do have to practices and clinicians, so if you do have a specific question, please feel free to reach out to us. This is something a bit new, is the physician and eligible clinician engagement. CMS is actually expected to roll out through us some educational modules that will have CME and CE associated with them, specifically geared towards the needs of eligible clinicians, and then beneficiary engagement. Speaking of webinars, I just have a list here of our upcoming webinars, including the next one is on February 16th, where we will be going over the MIPS improvement activities. We will also, in March, be covering the quality component. And then in April, really taking a deeper dive into calculating a MIPS score. So I touched on it briefly as it related in ACI, but to the ACI category, but this will be a good way to just bring all of the different pieces of MIPS together. And then I also wanted to invite everyone to our next office hours. We are holding office hours on a very regular basis. They're actually monthly, and it's the second Thursday of each month. The next call is actually going to be on February 9th. And so if there are questions that you have, or if this webinar has spurred some discussion and you'd like to, in your organization, and you'd like some additional clarification, please join us. These are fairly free-flowing, and they are really a valuable resource. These are the Lake Superior Quinn main contacts. As I mentioned, please feel free to reach out to us. If you do have any specific questions, CMS also has the QPP Help Desk, which I also have here, both a phone number as well as an email. You will also, just so you know, all calls basically to this Help Desk will also get the person in touch with the appropriate quality improvement organization. So in our case, it would be one of our 3 states if you do call in just to provide some additional resources and to build that relationship with you to make sure that you are as successful in this program as you possibly can be. And then I did just want to really highlight the fact that CMS has done an excellent job in their efforts to truly make a friendly and easy to navigate website. And if you haven't already visited, it's at qpp.cms.gov. There and a number of the different resources that I have listed in here, including the fact sheets. There's also specification sheets. So if you do have specific questions on specific objectives, please feel free to ask those questions now or during our open office hours. But if you do want to look at them yourself, they do look very similar in style to the specification sheets that were used for meaningful use, for those of you who are familiar with those. And then these are some additional resources to the full final rule. If you enjoy reading 800 pages of final rule. The executive summary, there's also to the quality measures. And then also the Lake Superior Quinn also has a number of, also has resources available on our website, including recordings to previous webinars. As I mentioned before, in November we had done an overview of the quality payment program, as well as letting you know about upcoming webinars and how to sign up for those. Here's a list of acronyms. And then questions. Also, please feel free to reach out to me directly. My name is Lori Mantefelt, and once again, this is my my contact information. And with that, I would like to ask our operator, Adrian, if you would please open the line to questions.
Thank you. We'll now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There'll be a delay before the first question is announced. If you're using speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have an audio question, please press star, then 1 on your touch-tone phone. And we have Emma Nelson online with a question. Please go ahead.
Tamara Nelson?
Oh, hi Tamara.
So we have just a question. We've been listening in here at Outagamie, and we have a question when it comes to the differences between EHR incentives, meaningful use, and the MACRA. I'm going to assume you can't file for both. Or can you?
Actually, you can, okay? Meaningful use lives on for the Medicaid EHR incentive program, all right? And so, for example, since I work with you guys, I know that you do have a number of clinicians or eligible professionals that do meet the patient volume requirements for the Medicaid EHR incentive program. And so that program will continue on, and the meaningful use measures will remain for 2017. It will be the modified stage 2, and starting in 2018, at this point, it would be moving to the stage 3 objectives. Now, if you also have clinicians, or that same clinician also meets the MIPS threshold, then they would also need to submit. They would be considered an eligible clinician for MIPS and would also need to submit through MIPS. So
that's the difference, because I'm pretty sure none of our doctors here are going to meet the 30,000 and 100 patients. But are there different thresholds if we combine them as a group?
Yes, there would be, but you would be able to be part of that. The threshold could be calculated as an individual provider or as a group, okay? And so in your case, if it is separate, if you're doing it individually, most of the time that would be the way that you would do that. Then you would not be MIPS eligible. I also wanted to point out two other things, and that is that CMS is planning on notifying clinicians. As a matter of the fact, we were told that letters were going to be going out by the end of 2016, although I have to admit none of the groups that I work with have received those letters, or I'm not aware of them receiving those letters yet. If anyone has received them, please let us know. Also,
they haven't
setting up a portal. Go ahead. I'm sorry.
Oh, hi, Lori. This is Candy. I just wanted to let you know I heard on a call last week that they are almost ready to go out, but that they have not gone out yet.
Oh, thank you.
And then the other thing, this is Candy Hansen from the from Stratus Health. And I'll just put out a little disclaimer that we're learning as we go, but it's our understanding that if you report as a group, that there is a possibility then that you would meet the thresholds, the MIPS thresholds, just by virtue of having a group combined. Is that how you understand it, Lori?
Yes.
Okay.
Thank you for clarifying that just a bit more. The other point that I was going to make is that I know CMS had also, and if you do have more details on this, please jump in, is going to have a portal so that you would be able to look up eligible clinicians as well to see if they're eligible or not based on NPI. Had you heard anything more about the timing of that? It's my understanding that it would be early 2017.
Yeah, I haven't heard anything more about that, Lori.
Okay.
This is Holly from Michigan. We
Yes.
actually did find out some information that they are expecting the end of the first quarter when the NPI lookup tool will be available.
Okay. Did you have any other questions, Tamara?
Oh, Tamara's not in the queue. If you want to queue back up, please press star 1. If there's any other questions as well, as a reminder, to ask a question, please press star 1.
One other question that had come through on chat is, can we be on 2014 search and try to submit the 2015 search ACI objectives and measures? I don't think that would be possible because a number of the objectives are only functional using 2015 search or are only measured using the 2015 search. I mean, if there were a way to do that, or if your EHR had designed a way to do that, I suppose it could be possible, but most likely not, because your EHR will not be certified to achieve meaningful use or those Stage 3 objectives and measures until that 2015 cert upgrade.
And we do have a question from Debbie Hoffman. Please go ahead.
Hi. I was just wondering if there's a way that we can print out the PowerPoint that went for today.
Yes, that will be sent out shortly after the presentation, and so you most certainly can send it out.
Okay. And then as far as, I'm not sure if we're going to be talking about this in a different section, but on the quality portion of MIPS, is that going to be covered in a future webinar?
Yes, I do believe that I don't have our full calendar in front of me, but I do believe that one is being covered, correct? I don't know if Candy or Holly.
Oh, Lori, that's our March webinar. Okay.
Oh, okay.
Okay, because I do have some questions about that because when you said, if you have a PA that can be excluded, but then your quality data goes up, so you kind of have to be strategic in what that quality data looks like and whether you choose to report on that person or not. That's absolutely correct.
Yes. Okay. All right. Well, more to come. Thank you.
And in fact, this is Candy, when we get to the scoring webinar in April, we'll be able to provide you some strategies around how you might want to look at, the entire scoring component so that you can be strategic to get the best results.
Perfect. Thank you.
And as a reminder, if you have a question, please press star, then 1 on your touch-tone phone. Waiting for further questions. And we have no further audio questions at this time.
Okay. All right. Well, I just wanted to say thank you to all of you for attending today's webinar. And please reach out to us if you do have any questions. We'll also be sending out a survey after this to see if how we did. So please most certainly send our feedback. I know personally I like to see your comments so that I can do a better job next time. So thank you very, very much for joining us today. Have a great day, everyone. Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating, and you may now disconnect.